bad ocular surface. Now, when we say bad, it depends on how we define the bad. Okay. So let us consider this patient. 67-year-old lady, arthritis, rheumatoid arthritis patient on systemic immunosuppressants, being treated on intensive lubricants for secondary Sjogren's. Vision is 636, 680. About 1 plus nuclear sclerosis, post-advice cataract surgery for vision. So Sharma's is 1 and 3, and this is how she was when she came to me. Okay, not much of surface inflammation, but then there is diffuse corneal staining. She is faithfully using her lubricants every hour, and so what is this a bad surface? Probably yes. Why? You can see the whole cornea is diffusely, diffuse erosions are there, and actually that is the cause for her loss of vision. And this is how she was 2 to 3 days after punctal cautery. The whole cornea cleared, and her frequency of lubricants reduced about 6 to 8 times a day, and vision improved to 6-9, which helped us to defer her surgery. So the first thing to do in any surface disorder is to assess the tear film and to address the problems there. It may be an aqueous tear deficiency, or it may be a lipid or meibomian gland disease which is there, and you address that. Now, this is another patient. Okay, Stephen Johnson, 50s year, somewhere in 50s, mid 50s. As you can see in this picture, the right eye is okay, the left eye red, patient is very symptomatic, as vision is low, and this is what you see when you pivot. There is dense keratinization of the lower lid, and he underwent a mucous membrane transplant for the lid margin keratinization, and this is how he is few months after the procedure. Quiet eye, comfortable, and there was a drastic improvement in vision. So this is another picture. Actually, this is not my photo. These are from Dr. Geeta Sakadadala photo. You can see the difference in cornea after mucous membrane transplant few months down the line. Okay, the whole, the keratinization has reduced, the cornea has become much more clearer, beautiful. You can appreciate the AC details better. So the next step is to address the inflammation on the ocular surface. So what can cause the surface inflammation? It can be because of the mechanical reasons like lid related, lid position related, entropion, trichiasis, lid margin keratinization, very common in Stephen Johnson's and other rare cicatricing conditions. So that is your next step. Address the mechanical reason. If there is any inflammation still persisting after you have taken care of your the tear film and then the mechanical factors, then you can attribute that amount inflammation to an immune reaction. Okay. There you have to think about immunomodulators, either topical or systemic, depending upon the condition. If it is an autoimmune disease like OCP or any of those things, you have to think about systemic immunosuppressants. So that is your next step. Now, what about case like this? A Stephen Johnson patient, vision is just counting fingers. You can see there is significant damage to the surface. There is that inferior is keratinized. If you can see, the limbus is not healthy. There is partial vascularization, feigned surface central corneal scarring, and this is a post-chemical injury eye. Again, partial stem cell damage, but center is reasonably clear. Vision is just counting fingers. Those cases are ideal for visual rehabilitation with scleral lenses. A modality of treatment which is horribly underutilized in our practice as of now. There are multiple reasons. Many of us doesn't have access to this, but more importantly, very expensive. Okay, with the availability of many lenses, it has come down, but still most of the lenses are more than 25,000, 35,000 for one lens. So many of the patients find it difficult to afford, but then can bring about a dramatic change in the life of these patients. So that is scleral lenses. Now, when there is chronic failure, you have to think about reconstructing the ocular surface. When I think about reconstructing ocular surface, I try to think in stepwise manner. The first is to assess the eyelids. Are the lids okay? Fine. Then you think about reconstructing the fornix and conjunctiva, and then finally come to limbus and the corneal epithelium. For fornix, And conjunctiva, as Madam Vanity Madam mentioned, you have to think of a simplified release, amniotic membrane. Now, what addition we need to do depends upon the regenerative potential of these conjunctiva. You need to have a good fornix, both palpable and fornical and bulbar surfaces. So, it is generally believed as per Seng that once you release the simplifera, if the conjunctiva is enough to cover the entire tarsal surface and beyond that on the palpable surface, then that amount of conjunctiva is enough to give the rest of the epithelium to cover the fornix and the bulbar surface. In those cases, probably an amniotic membrane alone will do. But if not so, you may have to think about replacing the epithelium. So how do you do that? You have to think about a conjunctival autograft or a mucous membrane or ex vivo cultured, either conjunctival epithelium or mucous membrane. And then finally, when you think about limbal stem cell replenishment, you basically first differentiate, is it a unilateral condition or is it a bilateral problem? If it is unilateral condition, then you are in a little safer zone. Okay, then assess that eye. How is that? Are the lids, the adnexs are normal? Is it moist enough? Then you can think about a stem cell transplant. Okay, stem cell transplant can be used to be conjunctival autograft previously. Now it is the preferred one as a sled. It's a simple procedure. Again, Dr. Vanity has shown how to remove the panels and put a amniotic membrane on the surface. The only difference in sled is the amniotic membrane has to be glued onto the surface with fibrin glue. Okay, it has to stay on the cornea and it has to be not mobile. So the sutures along the edges alone is not enough. You have to glue it and then you take the about 1 to 2 millimeter of the healthy limbus from the other eye, chop it into small pieces, keep it on the surface, fix each bit with a small drop of glue and put a bandage lens. So that is sled for you. Has given excellent results. Now, what about the other extreme? Unilateral injury, but then the eye is very dry. There is keratinization. Lids are not normal. What will you do? I would say don't do anything. Okay, because none of the stem cell or biological tissue transplant is not going to work here. The only thing that will work is probably a type 2 or similar to type 2 keratoconus. Okay, and that has got its own problem. So in a unilateral case with a dry eye, probably it is better to leave it. Again, now coming to bilateral end-stage disease, if the eye is moist, options are transplanting a biological tissue or a K probe. Biological tissue, if you think about allografts, either keratolimbal allografts or live related. But the problem with allografts is we need to give immunosuppression to these patients. Okay, so expensive with all the problems, and as an ophthalmologist, I'm not very trained to give immunosuppression. You have to have the help of a rheumatologist or a transplant surgeon for the systemic immunosuppression. So in these cases, probably better than allograft, especially in our setup, might be a keratoconus. That took Boston type 1 keratoconus, and the Indian variant is available as a K-Pro. Now, on the other hand, if you have bilateral dry, severe dry keratinized tissue, options are type 2 or modified osteoendokeratoconus. So coming to keratoconus, yes, type 1 or MOKP. These are the two most commonly performed procedures all over the world. Type 1 is the most common one from Boston. It is available, or you can get from Oro Lab. Most of the preferred one is a phakic one. If it is a good pseudophakic, you can even think of leaving the IOL there. Surgical procedure is not that complicated. Anyone who has reasonable good experience in doing a penetrating keratoplasty can perform a Boston type 1 keratoconus. But the crux is in postoperative management and handling of the problems which may arise in these cases. This is how it is done. First you assemble the processes on a donor graft, then suture it off. You remove lens, if I can think about putting a zero per IOL if required. Now the other extreme, when it is bone dry bilateral condition, is performing a modified osteoendokeratoconus compared to type 1 K-Pro. very different ball game altogether. TDS procedure done in 3 stages in India. Stage 1 is essentially an intraocular procedure where we remove everything inside the eye. You remove the iris, you remove the lens, do a proper anterior vitrectomy, and more importantly, during this stage, you assess the posterior segment, assess the nerve, assess the retina. You can do an indirect through an open globe and see if everything is okay. Then you decide to proceed with the further step. This is a chemical injury with severe thin cornea. In those cases, you may have to do a corneal transplant. Otherwise, you can just reflect the cornea, do these procedures, and close it. The whole lens is removed after removing the iris. Do a vitrectomy. And here, you're suturing a graft, and then the graft or the cornea is covered with the conjunctiva, totally closed. It's total tarsorrhaphy. It's not a tarsorrhaphy, it's actually conjunctiva to conjunctiva edges covered. Then the stage 1B and 1C are done together in most of the cases. 1B is mucosa. You take the cheek mucosa, about 3 centimeters. Circular mucosa is taken. The previous eye is opened up. All the 4 recti are tagged. Okay, the mucosa is sutured onto the surface from recti to recti all over, and you leave it there. The same sitting, to take a tooth with the bone around it. Okay, usually the canine is preferred, and these are the steps. The canine tooth with the root bone is actually cut out. It's not a tooth which is pulled out. Okay, you cut the bone out, and then it is a root with the bone that is used. The enamel is cut and off. Cut and thrown away. It's finely made into a 3 millimeter thick lamina. To the center, you fix the optic cylinder, and this is implanted in the subcutaneous pouch. That is the end of stage 1B and 1C. You leave it there for 2 to 3 months so that the lamina gets a very good fibrovascular capsule around it. And then perform the stage 2. First, you reflect the mucosa, then you take the lamina from the cheek, trim out the fibrovascular capsule so the optic cylinder is exposed on both sides. Then refine the center of the cornea. Push one end of the optic cylinder through the refined area, fix it onto the surface, and then cover it with the mucosa, and the central part of the mucosa is open. That's the end of the surgery. But in these cases, MOKP is one of the K-bros that has been shown to have the maximum life or anatomical success rate in terms of retention of the processes, and the visual acuity post OKP is also supposed to be great. So why 2 types? As I mentioned, in Boston, it's like this. Yeah, in Boston you can do in wet eyes and normal functioning lids, while OKP you prefer in a dry eye, and the status of that doesn't matter at all. So with that, I would like to end, and I would like to, or rather I'm proud to say that at Giridhara Institute we have started the MOKP program. We have completed 1 case as of now. Started as a not-for-profit, venture under sponsorship from a trust. So thank you once again. Thank you, Sujan.
Thank you, Vinay.